Hey everybody, my name is Will Martin, and if you don't know me or if you're new to this channel, I'm a nurse practitioner working in emergency medicine. And on this channel, we like to talk about healthcare topics, things that are affecting our hospitals right now, things that might be affecting our EMS system. And we talk quite a bit about nursing topics and nursing issues like nursing staffing shortages. And that's what we're going to talk about today. In our hospital, and I think in hospitals throughout my area, and I'm in the Northeast United States in New York, we're having, again, a major crisis of staffing. It was addressed for a little while when COVID started to kind of wind down. Of course, we had a lot of travelers at one point. Those travelers have come back. They were gone for a while. They're back now. And we're seeing the same kind of staffing shortages that we were seeing a year ago. And the question is why? What's going on, and what's making nurses leave the hospital and work somewhere else? And I have to assume that they're working somewhere else because they have bills to pay, so they have to work. But the nurses that I've been talking to have all been seeking jobs outside the hospital, primarily because, number one, they're treated better. Number two, the pay is similar, if not higher, than what they're earning in the hospital. And number three, they're getting a little bit more respect, and they feel a little less threatened by the patient population that they're seeing, not just in the emergency department, but throughout the hospital. It's become a real epidemic, and something that I have seen since I've been in the business for so long. I've seen the evolution of the nasty patient over the last 25, 30 years. Really, in the last 10 years is when it's really become bad. And I think that that's driving a lot of people out of nursing. You get a lot of people that get into it for the right idea, but these are primarily young men and women. And if they work in the emergency department, for example, it doesn't take very long for them to realize that they're being verbally abused, physically threatened, on a daily basis. And it's not an overstatement. It's not an overstatement. I don't work in the ER quite as much as I used to, but I'm still there 1 or 2 days a week. And I'm just shocked every time I go into work and I hear the way patients are talking to these young men and women. An example, I wish I could quote what I heard a couple of days ago when I worked a 7 a.m. to 5 p.m. shift in our downtown emergency department. It's a level 1 trauma center. It's an urban center. And just to kind of set the stage, when you come in at 7 o'clock in the morning, there's quite a few people sitting in the waiting room, of course, but we have our hallways and chairs in the hallways filled with people who have come in late evening, the night prior, as well as through the night. These are mostly people that are homeless, that don't necessarily need emergency medical care, but they need somewhere to go. A lot of these folks have been thrown out of our local shelters. Our shelters have the ability to ban people from coming in, and that's what's happened with a lot of these folks. So the emergency department is where they seem to wind up. Now, some of them have legitimate problems as well. And I'll give you one example. At 7 a.m., I walk in, the hallways are filled, mostly with people that are sleeping on stretchers, sound asleep, or sitting upright in chairs, sound asleep. These are the folks that I'm probably going to be tasked with dispositioning within the next hour or two. They have been seen by a triage nurse at some point during the night. Nurses have been kind of surveilling these folks, making sure that they're breathing and that sort of thing. But beyond that, they haven't really had a thorough medical screening exam. So one example I'll give you is I had a man that was laying on a bed. His significant other, female, was laying on top of him. Both of them were sound asleep. The story that I get from the nurses is that he's here with an abscess on his arm from infection from IV drug use. She is there because she says she hasn't urinated in 24 plus hours. Now, both of those conditions are pretty serious, right? I mean, if you've worked in emergency medicine or if you've worked in EMS, you've probably seen some of the abscesses that can develop on someone's arm as a result of trying to, inject into a vein and eventually it just becomes infected. It becomes abscessed. It becomes necrotic, infected. A lot of these folks wind up with bone infection. They can wind up losing their arm pretty simply, pretty easily as a result of lack of treatment. So he has a potential legitimate problem. I wake him up first. He tells me, he says, listen, I just need antibiotics. He's pretty reasonable. He's not confrontational, and I'm not confrontational. And I'm saying, listen, I mean, from the sounds of what I hear, absolutely, it sounds like you need antibiotics. But, I mean, you might need more than that. I mean, you might need IV antibiotics. You might need admission. You might need debridement. You might need a surgical consult. You might need to go to the operating room if you've got a wound that's that dirty. So that's problem number one. I mean, he's potentially legitimate. Now, her story, according to the triage note, was that she hasn't voided in over 24 hours. Now, that's a pretty significant thing, too, because I can assume that she's also an IV drug user. She could have kidney failure. She could have any number of things that's caused her to have her kidney shut down as just one differential. So I wake her up. And again, I try to be very non-confrontational. I don't want to get anybody riled up first thing in the morning and at the very beginning of my shift. And she's relatively reasonable with me, but she's adamant with her story that she hasn't voided in over 24 hours. So, try to get a medical history on her. She's not very forthcoming, but I order some appropriate hematologic studies and ask the nurse to do a bladder scan, see if she can empty her bladder and get a bladder scan, see how much urine is in her bladder afterwards. So just kind of do a standard, straightforward workup. Not going to prejudge them for being homeless or anything. I don't care about any of that. I'm just trying to just treat them as I would treat anybody. So I go back into, we have a little radio room that's kind of off the hallway where we can chart, and I'm starting to put the orders in. And next thing you know, I hear this female patient just yelling, screaming at our nurses, who simply went over there to say, hey, I need you to get off of your man so that we can take a look at him, and also so that, we can get some blood drawn on you and, recheck your vital signs. I mean, standard reasonable requests. That erupted into a huge verbal dispute between her and the nurses. And I mean, it was F this and F that, and I'm going to come back and cut all of you, and, I'm going to get in your grill and all this kind of stuff. It's just, it's crazy stuff. If I could audio record it, which I can't and I won't, but if I could audio record it, I don't think many people outside of the emergency department would believe it. Well, I say that, but I think this happens even up on the nursing floors too. It's just terrible. But anyway, we get the two of them separated. He shows me his arm. It doesn't look as bad as I thought it would. I mean, there's no fluctuance. There's a little bit of redness. Nevertheless, I said, listen, you might need to come in for a day or two of IV antibiotics, and let's keep an eye on this and see how it goes. And he's like, no, I don't want to come in. I just want antibiotics. I want to go. All right. Well, so you have two choices. Either you fight with him to keep him admitted, in which case he'll probably walk out and won't get any treatment at all, or you give him a prescription for oral antibiotics, and hopefully he takes it, and hopefully he gets better and doesn't come back. But those are the two choices with him. So ultimately, I choose to give him oral antibiotics. I spend a couple of minutes with him, talking to him, saying, listen, buddy, if this gets worse, you need to come back. This could become really bad. He says, I know, I had this happen to me once before. I almost lost my arm. I understand. He seemed pretty reasonable. So I wrote the prescription for antibiotics. I discharged him. He decided to walk out of the ED, I think, to go out and smoke a cigarette. Well, there's a policy that once you leave the emergency department, you're out. And if you come back in, you're either coming back in as a patient, you're signing in, or you're going to sit in the waiting room, which is reasonable. So he came back in, and they did not let him back into the ED. They told him he's got to sit in the waiting room. The female patient, his significant other, becomes irate, just starts throwing anything she can find, throwing it at the nurses. I mean, nearly, hitting their head with, IV pole. There was an iPad on wheels that we use as an interpreter, and she flung that at somebody. We have security, obviously, in the emergency department. Every ED, I'm sure, has security now, but our security is really limited as to what they can do. They can't get hands-on with people. Being the ED, we usually have police that are there for other reasons, but at this particular time, 7 o'clock in the morning, we didn't have police there. And so our security did the best they could to try to get her to go, and eventually she did. But the whole time, I'm thinking, this is what our nurses have to put up with at 7 o'clock in the morning. And they're there for a 12-hour shift. I mean, they're going to be there till 7:30 at night. And maybe when I was back their age, I probably would look at this much differently. But I looked at it like, my God, maybe you can get through it today, but how do you come back and do this job day after day after day? And you're trying to do the right thing. You're trying to take care of people. You're trying to be kind and considerate, and you're not even given the chance. And I know some people could say, well, this was one example. There's obviously mental illness involved, and that's true. And that's a whole separate point, that I think mental illness is a huge part of what we're seeing in the ED. And it manifests in ways like what I've just described, with the fighting and the yelling and the screaming and the threatening and the throwing things. Mostly that's mental illness. But how that's manifested in the amount of, the amount of violence and the amount of threats that occur, I think that's just a very clear reason why we're suffering from a huge nursing shortage. Nurses don't want to work in that environment for very long. I mean, some might find it interesting or exciting for a while, but for some nurses, once you get a little bit older, you start to have a family, you want to have a normal life and work-life balance, it becomes less and less attractive. So those nurses are going to go work in an endoscopy suite in an outpatient setting, or maybe they'll work in an urgent care somewhere, but they're not going to work in the emergency department. So we're going through a huge shortage of nurses in our emergency departments once again. And again, this has nothing to do with COVID. And this is the other thing that really gets me. When I read some of these journal articles, it always seems to bring up, well, with the aging baby boomer population, the baby boomers are not in our ED as much as you may think. I think the baby boomers, for the most part, are the ones that have understood how to access medical care. Some of them are insured. Some have Medicare, of course. Some of them, I'm technically a baby boomer. I'm too young for Medicare. I have my own insurance. But I think most baby boomers can access medical care. And those that can't, obviously, are going to be in the emergency department. But our EDs are filled primarily with manifestations of mental illness coinciding with actual disease. So it's a combo platter, so to speak, of problems that we're seeing mostly. But anyway, the result is you just don't have the nurses that are working in the ED anymore. Now, another big blow, and this is from more from the wound care perspective. When I go and work in my wound care clinic one day a week, completely different world. The folks that come into wound clinic, and these are folks that oftentimes they don't have insurance. 3 or 4 of my patients right now are post-gunshot wounds with paraplegia, people that have spent a fair amount of their lives in prison. But I'll tell you, they appreciate being taken care of. I've got great relationships with all of them because, you see these folks in some cases every week. And they get to know a little bit about you. I get to know a little bit about them. The dynamic is so different than the emergency department, which is why I think if you do work in a high stress environment like the emergency department or some other, clinic, you have to have something else to do. You can't just do that every day because it'll drive you crazy. But where I think I was going with this is that in settings like that, like the wound clinic, for example, much more rewarding, much more satisfying for the nurses, certainly a lot less chance of physical harm. But I think the point that I wanted to bring up was that I rely on home care services quite a bit for my patients so that they can have their dressings changed. We just had a couple large home care agencies just shut down just in the last month or so. And I still don't know why. So I don't know if they shut down because of financial reasons, or probably more likely they shut down because they don't have enough nurses. This is just really difficult to understand, even from somebody who's been in the business for a long, long time. Where did everybody go? And what's the reason why there's such a shortage? So tell me what your thoughts are on this and what I've said. Do you work in the emergency department? Do you work in EMS? Do you see this sort of thing every day? Are you working up on a regular nursing floor, like a med-surg floor? And are you experiencing the same type of poor behavior and mistreatment that our ER nurses are getting? Because I'm sure it's happening upstairs. I just don't venture up there anymore. But I'm sure this is pretty universal now, and pretty sad, really. So leave some comments and tell me what experiences you're having, and I'm sure it'll generate a pretty lively discussion. So anyway, next time we'll talk about some other topics, and until then, talk to you soon. Bye.